Welcome to CFP Distilled, June 2023. Every month we take a look at the CFP journal and we look for the clinically relevant pearls for your practice.
And for the exam, but what do we start with? We start off by looking at the outside cover, and you know what? I think this is my favorite so far. I'm gonna give this a 10 out of 10.
I'm actually really impressed. So this is Zachary Logan's queer self-portrait is how he describes it in the description.
It's his face and then this beard that goes out into this beautiful floral bouquet. And we have a floral bouquet of articles and tips and clinical pearls. Let's dive right in.
The first article we want to look at is about anorexia nervosa and a new diagnosis you need to be considering in patients with eating disorders. There are two diagnoses you need to know when it comes to eating disorders, and I'm not just talking about anorexia and bulimia.
So what else could it be? Let's talk about anorexia nervosa with one thing missing.
So if you got the diagnostic criteria, you've got those three things you need for the diagnostic criteria. You've got your
Fear
of your body shape. You've got your disordered eating restriction. And you need a third thing, which is loss of weight, abnormal body shape. That's your diagnostic criteria for anorexia.
So what if you have that absence of being underweight? What do we call that? Now, I didn't know this until I read this article.
It's called atypical anorexia nervosa. I'll say it again, atypical anorexia nervosa. Add that to your lexicon. You need to know this one for the exam. It could show up on your next SU.
So what else do we have to think about in these patients? When do you admit them? When are they so sick? What are the things you need to be looking for, Simon?
Bottom line, abnormal vitals, abnormal labs, abnormal findings.
Whoa. You can't just say that on the exam. Remember, we're trying to prep you for exam success. You gotta be specific. So you've gotta be writing heart rate. You can't just write abnormal vital signs. Be specific about what you're looking for. Could be an abnormality on ECG. Maybe they've got a prolonged QTC. Those are things you're gonna look for that are gonna lead you to potentially admitting these patients when their illness is more severe.
These are also things you're going to be monitoring for these patients, including blood work. So, for example, the people who wrote this article would probably fail a SAMP on this because they said get CBC and get your lipid profile and get your electrolytes and get your liver function tests.
Can't do that. You have to be specific and write the specific indices on the exam.
So for your SAMPs, one answer per line. These are all the things we're going to be monitoring for these folks at every visit: the vital signs, the labs, weight and height, mental health concerns as well.
And what can you do to help these patients, Simon? Two capstones of treatment.
Exactly. So the first one is going to be renourishment. We want to make sure that we're helping these folks without pushing them into refeeding syndrome.
And the other thing is going to be the cognitive behavioral therapy, psychotherapy. That's the other thing. That's kind of proven. But what's something that's emerging? What other medication could you potentially be using for these patients?
Yeah, there's a lot of research on this. The studies are small, they're conflicting. So some centers are using medication, specifically second generation antipsychotics.
So consider that as part of your arsenal when you're treating these patients.
It really comes back though to the family therapy, getting the family on board. This is what the SU would be all about, is finding those social dynamics and the layers and making sure you're getting them involved in the treatment.
Absolutely essential. There you have it, a great article. You can read it start to finish, but we've summarized the key points for you here today. Let's start with a hard-hitting tip about concussion. When do we get these kids back to school?
So there's an article in the June 2023 CFP journal, but it also complements the brand new guidelines from Amsterdam introducing the SCAT-6.
Wow, SCAT 4, 5, 6. It's always improving, always changing, and we get the updates at the review course in family medicine. But let's talk about this particular article. What are the things that we really need to start changing when we're treating our concussion patients, specifically about going back to school?
So when it comes to going back to school, we used to say rest. You got to go do that gradual return, make sure your symptoms are gone at the first step, and then maybe in a couple of weeks you can be back at school. That is gone.
So what we want to be thinking in the back of our head is we do not want to miss a complete week of school. 24, 48 hours rest, sure, definitely not playing again on the day of injury, but then we got to get these kids back to school. They improve better, even if they're still a little bit symptomatic.
This is going to make a great SU because the parents are going to say, no, they can't go back to school. They keep asking to come home from school. So how do you manage that?
So find a space at the school that they can rest. You don't want them to be coming home. And who's that key person that you could bring in?
Exactly. Every school should have a point person for pediatric concussions. Identify them, say we're going to have a group meeting with them. We're going to conference them in, coming up with a plan for this patient.
That's amazing. So some great tips. We want to get these kids back to school, in school within 24 to 48 hours, even if symptomatic.
This recommendation for pediatric pneumonia feels like malpractice.
What? What are you going to do? Are you going to say give 3 days of antibiotics for simple community-acquired pneumonia?
If the kid's vaccinated, we used to give 10 days and now it's to 5 days, and it turns out 3 days is non-inferior.
This is a challenge, and I think when I go into practice, it's like it feels so weird to write 3 days of amoxicillin. You're like, this isn't going to do anything. But the numbers are actually quite robust.
They've studied thousands of kids. There was big trials with 800 kids in Ireland and UK. There was a meta-analysis with 9 trials showing it's safe and effective. 3 days.
3 days. So this is what I'm doing. If you have the ability to have some follow-up, you know what? Give the 3 days, see them, and you know what? We could be decreasing antimicrobial resistance, less antibiotics for these kids, better outcomes all around. 3, not 10 days. What is that on your arm? Is that what all the cool diabetics have?
Yeah, well, you know, they've all got their continuous blood glucose monitors, and they do that thing with their phone. They go boop, 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 and they're testing their sugar. And I mean, how cool is this? And why don't we just... Okay, it's a gum wrapper package, but I just thought I would see what it's like just for one day.
Highs and lows of being a diabetic. So what are the actual benefits? Now, this is expensive.
Well, it's not that expensive. It's only $6,000 a year.
That's like the cost of one CCFP exam.
Well, how much is it really? Like if you're doing 4 times daily blood glucose monitoring?
It's $1,200 a year.
Okay,
for that.
so big cost difference.
5,000, like you could, I don't know, you could smoke a lot. You buy cigarettes with that money.
Don't start smoking, kids. Let's not recommend smoking on the CFP Distilled podcast.
Medical. Stop joking, Simon. So what are the actual medical benefits?
It's got to be really useful. Like you wear this monitor, you know exactly what your sugar's doing.
It connects to an app.
Exactly. Less hypoglycemia. Isn't that what's going on?
Less severe hypoglycemia in type 1 diabetics. Isn't that amazing?
Turns out it's actually marginal. So people who have the continuous blood glucose monitor, 6% of them are going to have severe hypoglycemia compared to 8% who don't.
Okay, I mean, I think ultimately patients are going to make their own decisions. A lot of my patients really love the beep, boop, beep. But what about type 2 diabetics?
Type 2 diabetes, isn't it going to lower A1C and have less hypoglycemia?
Yeah.
Turns out it doesn't.
No.
Right, so not that great when it comes to the benefits. Lots of people still have them. You go to the pool in the summer, you see lots of people with their continuous blood glucose monitor patches on their arms. People are buying them, people are using them. So it turns out sometimes the patient-oriented benefits aren't great, but the patient still want it.
That's it for the June CFP Journal. Distilled down some key points. We hope you learned something. Hope to see you at our next CFP Distilled podcast or in August at our course live in Toronto.